Welcome everyone to the April 30th COVID-19 clinical care rounds focused on emergency department patient care and clinical operations. I'm Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 emergency department challenges and successes in patient care and operations. This is a voluntary public-private collaboration, thanks to the multiple professional organizations who have collaborated on these rounds. These are not intended to be redundant or replace any organization's initiatives. They are intended to be a sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care with other clinicians. These rounds are in many ways similar to what military medicine did in Iraq and Afghanistan to identify what works and what doesn't work, refining it over time and embracing a culture of continuous improvement. Thanks to Project ECHO, Dr. Bruce Strubinger and his team for the peer-to-peer learning platform that we're using for these rounds. I'm going to give some announcements about some upcoming events, and I know announcements can be tedious, yet the following information is really important to share with you. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Tomorrow, Tuesday, April 30th, noon Eastern time, COVID clinical rounds will be having a special session on long-term care facilities, patient care and operations. While I'm aware most participants today don't work in long-term care facilities, given the impact of COVID-19 on long-term care patients and how that impacts the entire healthcare system, I encourage you to consider listening tomorrow. Mondays, next Monday, EMS, next Tuesday, critical care, next Thursday, emergency department, and we are actually planning in the planning stages for a special session potentially as early as next Friday on PPE preservation strategies. When we send out announcements for upcoming rounds, you'll frequently see speakers to be determined. We work to identify speakers and topics just in time, given the rapid changes in experience with this pandemic. For the ECHO rounds to date, we've had participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians, but other disciplines as well. Appreciation is extended to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO rounds and NETEC's webinars are complementary to each other. Sharon Van Arsdale, if you could please introduce yourself representing NETEC, and if you want to share your resources with the audience, that'd be great.
Yeah, hello everyone. My name is Sharon Van Arsdale. I'm the Program Director for Emory Serious Communicable Diseases Unit and the Director of Education for the National Emerging Special Pathogen Training and Education Center. And as Rick mentioned, we have several resources available. We have a COVID-specific landing page for anybody looking for additional information. We have several webinars that we have recorded, and we have several webinars coming up as well. Yesterday, we just did one on ethics, so that's triage and beyond, and that recording will be available online, as well as one tomorrow. Based off of a lot of feedback we got from these clinical rounds, we will be doing one on prone positioning and the implications for your patients and your teams. And so this is proning across the continuum of care. Yes, we hope that you will be able to join us.
Thanks, Sharon. Additionally, we have a representative from the Association of American Medical Colleges, Dr. Rosha McCoy. And Rosha, you want to speak to your clinical resources, clinical guideline resources?
Yes, we have, I mentioned before, the clinical guidance repository, an online open access repository of clinical guidance from institutions around the country. We're also in the process of putting up some alignment documents, staying away from the word guidelines, but alignment from different institutions looking at specific areas. So we have 3 that are going up, one on critical care management, one on infectious disease management, which we just updated based on the new guidance on hydroxychloroquine, so trying to stay as up to date as we can, and also ECMO document going up shortly, which is aligned with the ELSO guidelines. So we have a lot of specialty documents as well. So we hope this is useful to folks, and we would love your feedback. Thank you.
Thanks, Rosha. A special appreciation to the American College of Emergency Physicians and the Emergency Nurses Association for their support of these rounds. And welcome Dr. Sandy Schneider, who we'll be introducing in the near future, who represents the American College of Emergency Physicians on our panel today, and look forward to hearing her after our first couple of speakers. Let's see, I want to let you know that we continue to receive many questions for each of these rounds, and apologize in advance that we're not able to answer all of them. I will say that the number of questions has gone down, but many of the issues remain the same. We've selected many major themes from those questions and hope to cover some of those. With that, I'm going to turn this over to Dr. Struminger for him to give us some housekeeping tips here.
Great. Thank you, Rick, and thanks to all the attendees. There are about almost 500 people attending today, and to all our presenters and panelists. So just a few quick housekeeping items. There's a Q&A function in the bottom of the Zoom toolbar at the bottom. Please put your questions and comments related to the presentations there. There's a chat function as well, and we're going to actually bring up a crowdsourcing question that we want you to give your feedback to that and put it in the chat. But if you have technical or logistic questions, please put those in the chat section as well. We are recording this session, and your attendance is consent to be recorded, so thank you for that. The slides and a link to the video recording will be shared after the session via email with everyone who registered. They're also at the bottom of the email announcements, access to prior PowerPoints and recordings, and there's also a web page that we'll share a link to that, so you can access all of that in one easy place. There will be CME and continuing professional development credits through the University of New Mexico. We will put a link in the chat at the end of the session. There's also a link in the most recent announcement that went out a few hours ago, so you can just click on that link. We really appreciate the feedback we get from the survey that you complete to get that instant CME. So we really encourage you to get the CME and give us your feedback so we can continue to improve these clinical rounds. And with that, I'm going to hand it back to Rick to go over this crowdsourcing question we want your feedback on.
Yeah, thanks, Bruce. I think of the many questions that we've done in crowdsourcing and polling, this one is critical that you help us understand the answer to this question. What has been most effective in supporting the mental health of yourself and your fellow emergency department physicians, nurses, and staff? Again, what has been the most effective in supporting the mental health of yourself and your fellow emergency department physicians, nurses, and staff? I think in terms of like self-help, maybe some of the answers we get here may be helpful to all of us. So with that, I want to go ahead and introduce our panelists, or actually ask them to introduce themselves. Speakers and panelists, if we could, each of the speakers and panelists, take yourselves off mute, and we'll go around the Hollywood squares and do self-introductions with your name, title, and affiliation. So Nancy.
Hi, Nancy Pook. I'm an emergency physician in Dayton, Ohio, affiliated with the Kettering Health Network. I am involved in many levels, including the Network Operations Command Center. Proud to be an emergency physician my entire career. Thank you.
Thanks. Bruce?
Hi, everyone. Dr. Bruce Struminger. I'm a general internist at the University of New Mexico and associate director at Project ECHO.
Jolien.
Hi, good morning. Jolien McGreevy. I'm the medical director of the emergency department at Mount Sinai Hospital, and also a clinical ethicist by training. and I teach at the Harvard Center for Bioethics.
Sharon, I think we've gotten you introduced, so appreciate that. And Sandy.
I'm Sandy Schneider. Excuse me. I'm Sandy Schneider. I'm the Associate Executive Director at ACEF for Clinical Affairs. I'm also a practicing emergency physician and could not be prouder of our profession at this point.
Thank you. Rosha, I think we've gotten you introduced, so Paul.
Paul Bittinger, same comments about proud to be an emergency physician and director of the Center for Disaster Medicine at Mass General.
Thank you. Thank you all. With that, I'm going to turn this over to our first speaker, Dr. Nancy Book. She's the medical director of Network Operations Command Center, the network emergency medical director for Kettering Health Network. She's the physician advisor for COVID-19 Incident Command and vice president and board member for EM Specialists Incorporated. So Nancy, please, and do the slide share thing, unmute yourself, and you're off and running.
Let's see how quickly I can get this going. Here we go. So thank you so much again for having me participate. I'm right in the middle of the country, and as we were talking a little bit earlier, so blessed to be able to learn from the experiences of both coasts as well as from other parts of the world. So we have been able to gain so much from the experiences from so many other places. So this is the data from yesterday. There were over 17,000 reported coronavirus cases. As of yesterday, it's typically reported at around the same time every day. What you'll see in the northeastern corner is where Cleveland is. Right smack in the middle is Columbus. We are in the southwest corner, and where you see Hamilton lit up, that is where Cincinnati is, and up and the top where Lucas County is, that is Toledo. Now, Rick pointed out about a week ago that, hey, we're seeing these numbers climb, and there are a couple of areas that I want to point out to you. One is Marion County, that it has a high level, and the other one is Pickaway. And there are two large prison systems that have a lot of disease. And I'm going to tell you that we haven't been able to test many people outside of hospitals. And so those numbers, as we go forward and start testing more broadly, we expect those to continue to climb. So of those patients that have been identified, these are the numbers: over 3,000 hospitalizations, 1,000 in ICUs, and around 1,000 deaths. In our local network, we have had about 1,000 inpatient PUIs. Looking at age, and they're 50% are over the age of 80, and around 30% were nursing home patients. So one of our first hotspots regionally was a long-term care facility, in fact, a region of them. And we see higher numbers of deaths there than we did even in the two counties where there were prisons. And that's because of the age range and the comorbidities, et cetera. We're seeing ages from less than 1 to 106 with a median age of 51. And again, males somewhere around 57%, so more than females. Looking at the race disparity, I just wanted to show you that in Ohio, about 82% of folks who live in Ohio are consider themselves white, and you see that there's a discrepancy between the race distribution and the amount of disease. So around 58% of those who have been identified with disease are white, and 28% Black, as opposed to the general population of 13% Black. So we have to talk about Wine with DeWine, because that happens every day at 2 o'clock. So Governor Mike DeWine gets on and makes a big announcement, along with the director of ODH, Ohio Department of Health, Dr. Acton, and typically with some others. And this is how we get the information from the state. We also send information to them, as well as needs through some channels that we have here locally. So just in general, we started to really pay attention to this at the end of February, when we were starting to see cases in Washington state. So we were able to really kind of pick up and learn. But March 9th, with 3 cases and no deaths, is when the state of emergency was declared for the state. On March 23rd, the stay-at-home order went in place, and that includes restaurants, barbershops, salons, any place that could take more than 10 people in general. In addition, the elderly are really recommended that they stay at home at all times. There was a coronavirus.ohio.gov website that was set up for information, which has been updated on a regular basis. And early on, we were receiving a lot of calls. Hey, what do I do? I think I might have this. What do I do? And you know how we're not allowed to give advice over the phone. So this 1-833-4-ASK-ODH number was set up to run 24 hours a day. I think they've cut back a bit now, but in order to answer those clinical calls, that was set up pretty early. And as we will talk in a minute, moving forward into the Restart Ohio, it will be actually happening tomorrow. Some of the things that have happened locally is the National Guard came through in early April, and they looked through our region and our resources. You remember that early on there was some question of, did we have enough beds? Did we have enough ICU beds? Did we have enough ventilators? And they came and toured several of our sites, and there was an initial plan to set up the large convention center as an off-site treatment area, but it will not be used. We have plenty of capacity. In fact, capacity is partly our problem right now. We're at about 51% in our network. So talking a little bit more about the hotspots, we talked about the skilled nursing facilities. That hasn't been a huge problem here. But the 2 areas where there have been large numbers, and mostly it's because of testing. So what happened about a week or 10 days ago is there were people who were starting to get sick in those 2 counties with large prisons that we talked about. They mass tested everybody and have come up with around 4,300 positives just in those 2 institutions, both the inmates and the correctional facility workers. There have been deaths in both of those populations. So it's a real concern, but it also shows the level of testing that can happen should it be released. We're still limited even today at testing the inpatients who come in, as well as a few outpatients can be sent to a couple of tent facilities where they're doing outpatient testing, but it's fairly limited even to today. It's in the numbers of hundreds for a million-plus population. So that's what testing looks like. We expect it to expand to testing every single inpatient within a couple of weeks, but we're not even ready there for next week when the elective surgeries go live. We've gone through all sorts of variations of PPE, from the initial place where literally people were stealing boxes of masks and they had to be put aside so that the healthcare workers could wear them. When we opened up our regional cache of N95s, there was a problem, and the masks are fine, but the elastic it hasn't worn well over time, and we estimate that these have been in storage for over 10 years. So it really created a problem when you think you have a certain number of thousands of N95s and they're a one-time use. That really early on limited the availability to even use them. We did have PAPRs from the very beginning and really got comfortable using them. And this is what today's PPE recommendations look like. Basically, as we go to work, we all wear masks of some sort. And if we've been exposed, as we all have, that is where that middle portion goes. And all healthcare workers are assumed to have been exposed, whether testing existed or not. And then for higher level intubations, aerosolizing procedures, et cetera, really limiting the number of people that are involved in the care, as well as providing the highest level of care. So we see in that one N95s, but truly if we're intubating, it's video laryngoscopes and the use of PAPRs, limiting the number of people in the room. We've had to make accommodations. We have a couple of emergency medicine residencies in our system, and the residents are not involved in the intubations. They will come in later to do lines potentially, but we've had to make significant changes, just as everybody else has around the country. The students are gone and the staff is limited. In addition, there's another piece that we put into place, and that was adjusting trauma. Who responds to traumas? Basically, the entire team comes down for a category 1, but otherwise, the emergency physician and a limited crew is used so that we're not exposing a number of people or burning through PPE that we weren't sure early on that we had. That will go back to a more normal protocol on Monday when the elective surgeries go back online. We're fortunate in Ohio to have a lot of great facilities doing a lot of good work, from the universities that are all across our state to Battelle, which is located in Columbus. And the advantage for us is that when we didn't know if we had enough N95s and they were really being rationed, Battelle came to the front and they said, oh, we think we can decontaminate these. And they put into play, they got an FDA emergency use authorization for a vaporized hydrogen peroxide protocol that has been put into play and really has changed. It's been a game changer in terms of what we think we are able to continue to do. We have plenty of gloves. We have general masks, which we know have limited capacity to protect us. But the N95s, we think we can use these up to 20 times as long as they're not soiled. And that is a real game changer, especially when you understand that a lot of our elastics have been broken in those that were stored for a long interval of time. This brings it down to where I am and where I work. I go to all of these places except for the most southern facility. There are 8 hospitals for freestandings. We go from inner city urban, where I worked yesterday, to the most rural environments. And there was a big change immediately. There are COVID units only at 4 of the hospitals. A couple of them were stripped down to bare bones. As you know, their testing is not available everywhere today. So testing is really only available at the main site at Kettering, and that's a PCR that'll generally be available the next day, although we're getting closer and closer to something that's same day. The operating room capacity was also restricted to 4 facilities, GI available at 4, and we subsequently shrunk down the COVID unit that is available on the east side, bringing those patients more central. So there's a lot of patient movement, especially when we're talking about the suspect patients, and bringing them to the highest level of care, or the most appropriate level of care where they need to be. So a lot of changes in that regard. And even more so as we ramp back up, there will be more capacity to do surgery, but the COVID units will stay the same. Now, what's been done in the emergency department is there's a split level triage. So there are Patients are identified as suspect versus non-suspect. So your general unstable angina type patient is going to go into the general population, whereas somebody with respiratory symptoms and fever goes into a COVID suspect area. Now, is there crossover? Well, of course, because patients with diarrhea and abdominal pain, we've seen peripheral opacities on their abdominal CT. So we all know that that happens. We're using the right level of PPE at every available site, and really have had to rethink how we do things quite a bit. We have a little bit of an advantage in our weaknesses in Dayton from the naming of Dayton as the, opiate as kind of #1 area for opiate overdoses in late 2017 to the tornadoes and the mass shooting that happened last year. What it's done is created a very strong infrastructure from the different hospital systems to public health to every level of the government, criminal justice system. And so it's really kind of put everybody on the same playing field so that when we have big problems, we have a big plan of attack to be able to handle them. So we have a real problem with disease, but it's low level. And we have hotspots in general in Ohio, but in Dayton as well. So what's happening next? Restart Ohio has been planned out with the governor and his team. What it means is that elective surgeries will start happening tomorrow, although we're starting on Monday. These are surgeries that do not require an overnight stay. In place prior to this have been the usual kind of essentials. They will still continue to be reviewed by a surgical review team. There will be continued surveillance and increased contact tracing as we open more industries. So there will be more of the manufacturing businesses and office businesses that will be open starting tomorrow. From a business standpoint, they'll be required to wear some sort of a face covering, but not necessarily a medically rated mask. We are working on what we call the long stethoscope, and that means putting video teleconferencing in with the patient. So if you're a suspect patient, trying to get it down to that one touch point so that we're not burning through PPE unnecessarily. As I mentioned, we're increasing our level of service at all of the facilities, and that includes trauma. So we will go back to our usual trauma protocols. And then finally, expanded testing is anticipated with every single patient who stays overnight in the hospital receiving testing. And when they come back, they are anticipated to have testing at that point as well. So let's say they fail their discharge plan, they would come back and be tested again. So that's a general view of our environment here in the southwest corner of Ohio and Ohio in general, and what we've been dealing with. And again, thanks to those who have gone before us, because we've learned so much from you. One of our biggest challenges from a business standpoint really is how do we manage at 50% of our patient census when we have no visitors allowed, and trying to get historical information regarding the patient that sits in front of us and passing that information back to the family. Those are some of our ongoing challenges.
Nancy, thank you very much for your presentation. Covered so many critical topics for every emergency department, every emergency physician, nurse, and staff in the nation. So I really appreciate that. And wonderful. In the interest of time, to make sure we have a chance for a really good discussion. I want to turn this over to our next speaker, Dr. Jolyon McGreevy. Jolyon is the medical director for the Mount Sinai Hospital Emergency Department. He completed his residency at Boston Medical Center, Boston University School of Medicine, and has served as a clinical ethicist in both Boston and New York, and teaches at the Harvard Center for Bioethics. So Jolyon, please.
Thank you so much for having me. Good morning, everybody. Can you see my screen? Perfect. So I was on, I don't know, it feels like 6 months ago. It probably was about 2 weeks. And, I'm coming back really to talk about what's changed. And this is sort of just a story of where we've come from and where we're going, kind of in high level themes that my team is using to kind of guide what's next. So, I say the road back, it's pretty clear that we're never going to go back to where we were, and that's probably a good thing. So it's really, I think, the first key is for us thinking not just about the road back, but really what the road ahead looks like. What's changed for us, so as a society, I suppose in the era of COVID, but in particular as a hospital and as a health system, because this has really been a forced opportunity to try things differently, things that may have been in the back of our mind around better triage, better flow. And we've had to do them to maximize our resources. And so to what extent can we use some of those things that we did during COVID to take us into the next era? To what extent will the mindset of all of our emergency physicians, our hospital leaders, our system leaders, and our leaders in government, change and allow us to really make some good progress, I think, in creating more streamlined emergency care. So the first thing I want to mention is that, when this all started, we thought about our people first. What is it going to mean for them to be on the front line? How are we going to protect them? I think as Nancy described, we have gone through every iteration of PPE. And a lot of that was through pretty significant periods of uncertainty about what the safest thing is. And so that created a lot of strain. We spent a lot of time communicating with people every day, making sure that we huddled with the entire staff twice a day, and that was really helpful. And now, sort of the road back or the road ahead, it's really thinking about the aftermath. I think kind of looking at people and talking to people, it doesn't really seem as though this has taken a significant toll on our staff, and I know that that is false. That is absolutely false. And as we know, there have been deaths among our colleagues from COVID, suicides among colleagues from the stress and strain, and thinking about what that's going to look like over the next weeks or months is critical. The key question was sort of what has worked. We tried many iterations. We had mental health social workers down in the department that were dedicated to us, were there and available to have conversations one-on-one with people. They basically were not used, despite being introduced day in and day out. Psychiatrists, same deal, basically not used. Every week when we did a faculty check-in, PA check-in, resident nursing, et cetera, people said, we appreciate those resources, but they just don't really speak to our experience. They don't really know what we're going through. And it's not that they'd even tried. That was just sort of our staff's perception. What's been really helpful is colleagues. And so we have buddies, and some of our folks who have served in the military suggested that we really do a battle buddy approach to this. And that's what we started to do. I don't know whether it's going to work or not work, but that's where we are. And, I look forward to some additional guidance from ACEP and others about how to do this well. Actually, sorry, the one other quick thing I want to mention about this is that the stressors early on were really about, will I be safe taking care of patients? Will I bring this home to my family? Am I going to be forced to make bedside rationing decisions that I've never had to make before? That was the stress and strain before. Now, as Nancy mentioned, there's a big business strain now that all of our physicians who watch the news and look at the overall census in the department have in the forefront of their mind. Our volume is down 50%. Some days it's been down 65%, which is really incredible. And people are wondering, well, am I going to be furloughed? Is my salary going to be decreased, right? And no one knows any of these kind of things nationally. And I think every health system that has gone through a tremendous strain is just running the numbers to try to figure out what this impact is going to be. And clearly, everyone is going to see the folks in the emergency department as having really served and been on the front line, no matter what the business is. But it really does impact, I think, how we think about the next couple months. Because what we can't do, I think, is sort of do business as usual with half the census, because that probably puts our hospitals and our systems and our people more at risk. When we started this, a big lesson for us was thinking in phases. So what that meant was talking to colleagues in China and Italy and other places to say, who are these patients? Who came to your emergency department? Early on, it was the folks that are walking with mild illness, kind of cold-like symptoms. So the first thing that we did was take over a clinic right next to the ER, turn it into a surge space, and we saw at the peak, 120 patients a day there. And at that point, we were testing just about everybody, and they were all positive. The guidelines shifted, over a week or two after that, and it kind of dropped, and we stopped testing as many people. But certainly, there would have been that amount of volume in terms of positive cases. So that was kind of first phase. We had a lull of about a week or so between that kind of fairly well cohort and the critically ill. And so in that period of time, we talked to colleagues from Italy, and they said, these people will come in crashing in respiratory failure. They may look terrible when they get to you. They may look okay. Either way, they're going to crash. Intubate them early. And that's what we did. They would come in, we put them on oxygen. They would get to 6 liters in a nasal cannula. For a brief period, we would try, high flow. We would try them on BiPAP, and then we would just intubate them. A week or two or a couple weeks later, we started actually pulling back a little bit to say, is that really the right thing to do? Might some of these folks do just fine on high flow? If we can get them in the right kind of room that's negative pressure, so we're not worried about the aerosol. Might some of these folks do fine on just on a nasal cannula prone? And that's kind of where we are with some of the mild people now, where the mild folks, who have a SAT in maybe the high 80s, we put them on a little bit of oxygen and prone them, and we monitor them in ED. Other folks will send up on high flow or BiPAP, and that seems to be working okay. Some of them crash, but not all of them do. My sense is that a fairly large percentage of people in our population did better than would have been predicted, I think, by the Italy and China experience, at least anecdotally from what we got from them. So the road back, I think, is similar, is thinking in phases. So where we ramped up that surge space for low acuity, we took over an observation unit to turn it into essentially a 27-bed critical care unit, and it was packed with like 5 intubations an hour at the peak. And we're walking that back now to say, how can we rebuild, our urgent care capacity? How can we start to separate and make the ED partially COVID, partially non-COVID, knowing that non-COVID is really a fallacy, that everybody's at risk. But generally speaking, can we start to try to separate this and make people feel a little bit safe? And that's kind of our road back. One of our lessons from a couple of weeks ago was really to think as a system, not to think as a hospital or a collection of hospitals, but at least in New York City, really a collection of hospital systems in an entire state. And the ways in which we collaborate, move things around, think about telemedicine, it really should not depend, the care that somebody gets really shouldn't depend what door they walk into. Anywhere they go, our ability to collaborate is really key. And that's been very effective with various directors around the city kind of talking about best practices and sharing. Every call that we're involved in is not an emergency department call. It involves ambulatory and critical care and telemedicine, and everybody else involved in trying to make sure that system resources are maximized. The next is really thinking about the fact that this really is not about COVID. And I think we've all known that in the emergency medicine world, that you're preparing for sort of categories of disaster, right? You're preparing for traumatic, bomb related, disaster, for active shooters, for infectious disease, that, there's sort of a variety of categories, but you really can think through all of this. And, I think that this was a big lesson for our health systems and the folks that don't necessarily do this, in understanding what it takes to build capacity and what their capabilities are. And, I think here we demonstrated that we could do it. At the peak, our hospital alone had something like 800 COVID patients in it, 200 or so in the ICU. We're down to about 400 COVID patients and I don't know, maybe 100 ICU patients or so. And they created that capacity really quickly, and thankfully probably stayed about a week or two ahead. That said, a lot of the things that we started to think about in terms of capacity, let's change a bunch of monitors so that we can, observe more people safely, when we intubate them. Let's bring in some CRNAs to help out the respiratory therapists. Let's bring in additional, physicians to relieve our staff. All that stuff came, but it came a couple weeks later than it was really needed. By that point, luckily, we didn't need it because the volume had dipped. But had it not, we would have been behind the curve. And so I think in the debrief, that's really important lessons for us. A note on crisis standards. So we, as a hospital, did not run out of ventilators, did not run out of ICU beds. That said, the state, I would say in pockets, came pretty darn close to that. And maybe there were, in fact, local shortages where people were forced to ration. We'll never know. But one of the things that we really, I think, observed when we started to try to think about the available crisis standards of care. So New York State has a document from 2015 around ventilator allocation from the New York Task Force on Life and the Law. Massachusetts put forward theirs, Pennsylvania and others. And they all have a sort of fairly similar structure, which is that when you're talking about this kind of a pandemic, the process involves some very limited number of exclusions where if somebody is in, cardiac arrest and sort of refractory and, at some point, you would just stop. Or if somebody is on multiple pressors, maybe you wouldn't, do CPR if they arrest, because at that point, adding that mechanical compression is not going to make a difference. But short of that, the mechanism is really a illness severity score based triage tool, where there's some sort of a clinical triage team that is removed from the clinical care that uses something like a SOFA score to identify who is in the red category, the patients who are most likely to benefit from something like a ventilator and most likely to die without it. That really takes time. And so when you're starting to think through that, it doesn't quite work that well, I think, in the pre-hospital and emergency department setting, primarily focused on the emergency department setting, I think, for this piece, which is, at the rate at which people were coming in respiratory failure and needing to be intubated, if we had to call a clinical triage team, we really would have had to intubate those folks, call the team, give them 30 minutes to deliberate, because it's hard to imagine they could do it much faster than that. Some of those people, in theory, were they too low on the list to receive the resources, I guess you would extubate them terminally. But so as you really started to try to think through what these state guidance would look like, you realize how big of a gap there is. That, some of the key principles around crisis standards are consistency, accountability, transparency, but also in there is efficacy. And I think it's really was eye-opening to us to try to think through what we would have done had we gotten there and realized how significant those holes were and how much more work there is, I think, to do in the emergency department for something like this, where it's sort of a slow rolling disaster over weeks to months. Clinical guidelines, I already mentioned some significant changes in our clinical guidelines over time, where, first we tested everybody, then we tested nobody. First we intubated everybody, then we tried not to. As data come out, and, we're doing a lot of research here on, things like, plasma treatment, remdesivir and some of these other things that, sort of that colleagues are working on. I mean, that's helpful, and it's starting to give more guidance on what works. Anticoagulation is another one, but still the data are not going to be complete enough to make, full decisions. And I think uncertainty remains. And one of the key things is to have some kind of principles in your guidelines for how you're developing them under uncertainty. And that applies not just to COVID, but really to non-COVID care and how we're going to get back to it. So an example might be STEMI care, right? So early on, the concern was that patients that came in with STEMI-like syndromes, are these patients with COVID and myocarditis, or are these patients with disease that is amenable to catheterization? And so that was uncertain. There's some guidelines from about a week or so ago from the Journal of American College of Cardiology that, essentially says, treat a STEMI like a STEMI, but, also add, doing an echo, confirming wall motion abnormality, some kind of other pieces, but don't let the fear of COVID fundamentally change what is otherwise a good practice for a disease. And I think that that's really a key lesson for us, making sure that we treat STEMI and stroke and trauma generally the same unless there's a principled or data-driven reason to do it differently that is in the patient's interest. And I think that's really key. Another piece, my kind of lesson from a couple weeks ago was that palliative care is a critical care resource. Now my thought process is moving forward, is this an opportunity to expand advanced care planning? I think we really learned a lot as a society about the risk for everybody of having no guidance for your friends and family about how you'd want to be treated if you became critically ill. Patients of all ages from all places came in, and some of them did well, some of them did not, and it really kind of got everybody. And so, I filled out my healthcare proxy again and sent it to all my family members during this because I think it's really so critical. We actually had embedded palliative care attendings and fellows down at our emergency department. We found that we were intubating so many people at a time that the attendings, although generally would be pretty good at having a goals of care conversation in a crisis or sort of with limited information and urgency, really could not do it when there were so many people to be intubated. And the kind of moral distress of worrying whether or not all the people that you intubated actually wanted it was a significant strain. So very, very early, we brought down palliative care attendings who had those conversations with patients. And most patients wanted everything, but at least they had a conversation to know. The strain on those people was also quite tremendous. Surprisingly, it was not the difficult conversation, from what I understand, that really was the most bothersome to them, but actually sort of how intimate it became for them to try to help the patients who were in the ER and their family members connect. As was noted, the visitors were not in the ER. And so, we had iPads, and these folks would set up the iPads with the patient and really just help them spend sometimes hours talking to their family, many of whom lived all around the country they hadn't seen. And that sort of involvement in people's lives probably created as much strain as anything and will stick with people. But, I think at best case, kind of advanced care planning work in the United States has never really taken off. At most, 20% of people have some kind of advanced care planning document nationally. That's got to change. This is really an opportunity, I think, to rethink, everything around goals of care and people's opportunity to express their wishes. The last piece, a few weeks ago, my takeaway was that it's all COVID. We had started with a respiratory zone, then that expanded into another zone, and at one point, I put up a little wall to try to separate one part of the ER from the other because it's generally quite open, and put COVID patients on one and non-COVID on another. That lasted about 72 hours, because after that, everyone with diarrhea, with chest pain, et cetera, was a COVID patient. And so my kind of takeaway a couple of weeks ago was it's all COVID. At this point, the question really is it still COVID? Because as we start to try to re-expand and separate the pieces again, how are we really going to know? Testing is really a challenge, and the false negative rate is very high. We have probably 30% or so of patients who are critically ill with a pretty clear COVID syndrome have negative tests. It's gotten better now that we're using tracheal aspirate, but it's still a significant challenge. And then how are we going to know in September or November when this comes back, right? That's really, I think, going to be our challenge ahead, and going to guide everything that we think about for the next few months. So I'll just stop there. It's kind of high-level lessons learned on, a road where we really had a roadmap in a way, because we had China, we had Italy to show us what to expect, and we just had to figure out how to stay a couple weeks ahead. This is a little different, I think, because the reopening of our society and the reopening of our hospitals is going to be much more unique to us, I think, than the guidance from other places will allow. So, I look forward to continued kind of conversations with people over months about what's working. Thanks so much.
Jolene, thank you. You and your colleagues your experiences have already helped a lot of us not just think, but actually respond to this. And I expect they will for years to come, probably decades to come. So appreciate your insights. Dr. Schneider, if you're on the line and still able to, really would appreciate your insights from the perspective of somebody that hears from emergency departments across the nation, and particularly focused on the mental health challenges that Jolene and others have spoken to and has been in the chat and QAs.
Yeah, thank you, Rick. This is like you guys set this up for me because what ACEP is doing really now is beginning to focus on, and I'm going to steal your term, Jillian, of the road ahead. The first thing we're talking about is coming out with some statements regarding what emergency care is probably going to look like. Some things like the typical crowded emergency department is a thing of the past. That there need to be barriers around so that people can work more appropriately, transparent barriers, but barriers. Hallway beds is just not an option going forward. And we have to start dealing with some of these issues that we have long complained about, but now it's not a complaint. It's really about the safety of our country. We are very concerned about opening up the country, about opening in both ways. Both were concerned that there will be a second wave and concerned that the volumes are down drastically and our members are being furloughed. And more important than all of that is that our patients are putting off care that they need. We hear story after story. Appendicitis is down, ruptured appendix is up. Number of limbs being lost. A patient signed out the other day with an acute stroke because he or she was afraid they were going to get COVID in the hospital and die, but instead went home where they could have been treated. I think that we're coming out, hopefully we'll have the statement ready in midweek next week, if not before, but it's going to try to deal with all of these, and we don't have the answers. No one really does. And as I said on a webinar just before this, we won't know who's right until this is all done. And then we can go back and look and see who was right. And what was right for one population is not going to be right for another. What is right for healthcare workers will not be right for waitresses and people who own bars. So defining right, defining best is not clear. We've been working with the American Association for Emergency Psychiatry for the last couple of days on mental health, and they told me something really important, and that is this is not mental health. This is actually normal health. This is what we were supposed to be feeling. But what we need to do now is let people know that A, it's what they should be feeling, and B, that we need to watch out for each other's safety. So we are going to be offering some webinars early in the week regarding both the buddy system that you talked about, the combat buddy system, but also training in how to be an effective buddy. And we're going to hopefully do the train the trainer approach to tell people how to be the best buddy for each other. The other piece of that is that we also recognize that the leaders need their own buddy system, and they need to be talking to their own buddies. And that the frontline person is maybe not the same, having the same experience as a person who's trying to fill the shifts and do that. So we will be doing a lot more in that. Again, I'll put a plug in for our field guide. We have close to 100,000 views on this right now, which is something way higher than we ever thought would happen. Member benefits. And then again, we're working on what it is to be an emergency physician, what it is to, what the road ahead, I'm going to steal that terribly now, what the road ahead is going to look like for ACEP, for our members and for the people that we work with and care, and most importantly for our patients. So thank you, Rick, for that opportunity. And I thank both of the panelists who went before me for sort of highlighting the fact that we're on the right road. And I have to get off to go do another interview or another webinar, another interview.
Sandy, thanks for all your work on behalf of emergency physicians in the country. Deeply appreciated. Jillian and Nancy, you both struck so many issues, or hit on so many issues that we've talked about now for, I guess we started these rounds March 24th, but what's different now is a perspective of this is what we did, now we've changed to this. Jillian, I was particularly struck by your comment about on the mental health piece with how you had mental health professionals down in the department and that didn't work. And Dr. Snyder and I actually were chairs of departments of emergency medicine about 100 miles apart during our careers. And I could tell you when faculty staff were presented with those opportunities to speak with mental health professionals, not so much. And so this, and we were talking about in the sort of like chat before we started at noon, how, this, it has been a little bit like a battlefield, a lot like a battlefield. And that buddy system, I'm fascinated that you've gone to that, and that ACEP is actually working on that as well. And I think it's going to be really important to learn about that experience. I mean, very quickly, just like it's been a month, less than a month since you spoke last. It's literally less than a month. So, I mean, it's very quick. And if that's working, that's something we're going to be inviting you back. I mean, it's really important to learn, for us all to learn. Next thing I want to do, we'll go on for until 5 after, but there's one thing that has been increasingly valuable as we've gotten more experience with these rounds, and that's a polling function. Okay, so I know some have dropped and so forth, but if you can stay on to do the poll, that will inform all of us about what's going on in the country. So if my colleagues at ECHO could pull up the polling function, that would be great. Sharon, I think we'll be done in 3 minutes, so you get a chance to vote. All right, so these are going to be lightning rounds. I'm going to do 15 seconds, 30 seconds. So this will be a 15-second one. On your last shift in the emergency department, did you care for any COVID-19 patients? Realize you have to do shifts in the emergency department to answer this. So go. All right, stop. Let's see what we come up with. Or is that, Echo, does that, we have to wait for all? Oh, okay. How about that? Wow, 50-50. All right, and by the way, we get a cross section of the country and the range of 15 to 20 countries represented on these rounds. So it's a pretty broad section. Okay, next question, please. Okay, this is a 15-second one too. Over the past 7 days, is your access to PPE while caring for patients, not what's in the stock room, but while caring for patients, better, worse, or the same? 10 seconds, go. And stop. Okay, that's similar in trend to what we saw with the critical care responses the other day. Next question, please. Okay, this one's going to tell you, this will be like a 30-second one. In your emergency department today, if you're in the emergency department today, which of the following PPE supplies are you most short of? One response, you only get one response. N95, any kind of mask, protective eyewear, gloves, gowns, or you're not short of any PPE. Go. We'll give it 30 seconds on this one. Uh, 3 seconds and stop. N95s and gowns leading the way. Okay, thank you. That's insightful. All right, next question. All right, in the emergency department, which of the following, well, wait a minute, I can't read it because a calendar invite popped up. Imagine that. In the emergency department, which of the following strategies are you using for COVID-19 patient ventilation support in the emergency department? Choose all that apply, and this will be 15 seconds. Start now. Give seconds here. And stop. Interesting distribution. Fascinating. You're looking at it right along with me. High flow nasal cannula wins the day for sure. Okay, next question. Well, this one's around alternate care facilities, and your experience with them. So does your community region have an alternate care facility that today is caring for patients? The options are yes, within 10 miles of my emergency department. The second is yes, within 50 miles of my emergency department, and then no. That's a 10-second one. Start. Okay, stop. Okay, all right. I don't know, Bruce, is that the end of the questions? I should look.
Yes. Yes, Rick, that was the
Great.
last.
That's just so you know, we number one, you get to see it right along with me, but we actually take that information and share it with, for example, NETEC has access to it. I mean, you all have access to it, but also we share it with leaders at HHS and FEMA, so they have a chance to see what's really good today. So it's extraordinarily useful, insightful information. So let me go just to one quick question for each of Nancy and Julian. In your experience, and it's a two-part question for each of you. First question is, since this began, what's the biggest change that has improved care in the emergency department? The biggest change that you've made. So Nancy, let's do that one first, and then I'll ask Julian the same question.
I'm going to echo what Julian said about systems practice. Instead of everybody having their own silos, we have a network system, in fact, regional systems that work well together now. And that's been a big plus.
Yeah, and in your case in particular, given, when I say yours, it's Dayton's case in particular, you certainly have had more than your share of challenges with large scale events or that has helped facilitate that for this response. I think that's accurate, at least from what I've learned from my colleagues there. So yeah, and Julian, what do you think? Best change? It's improved care of patients.
So I'd agree with that. I would just say very quickly, clinical, I think that the two areas are the when to intubate decision, and I think that's really been a change, the fact that we're staving people off a little bit longer. Another piece is recognition of venous thromboembolism has really been key, because people come in hypoxic, and you don't know whether they're COVID hypoxic or from a PE. So I think those are critical. But I think the system change really, though, is the biggest one. The ability, for example, to take the patients out of our smaller hospitals, we have 8 ERs, something like that, to take them out of our smaller hospitals and move them right away has been so critical to making sure that, the care that someone got didn't depend on what door they came in. As I said, that's been critical.
Yeah, and that's evolved too, because there was almost like you just take what you get rather than like, okay, let's do some load balance. And apparently that's increasingly been beneficial. And I also, intubation piece, your comments about the crisis care and how rapidly that decision making and that big hole that I think is really critical. And until you mentioned it today, I missed the hole. So, but then again, we never had the experience. So, last, what do you think, for your system, realizing, in many ways you're tip of the spear, sadly. But what do you think needs to be worked on the most to improve care of the patients in the ED in this response? Nancy?
I think having testing availability, just like we would have a flu PCR, that would be a game changer for us.
Thank you. Yeah, and Jolene?
Yeah, I think that's the case. You know, sort of, you know, better serology, I think too would be helpful. It's, you know, the fact that we really do have a 30% or so false positive rate, oh, sorry, false negative rate among the critically ill is hugely problematic because you're making decisions based on testing that you know is false. And I don't, it's challenging thinking about going to reopening ERs and or sorry, ORs, you know, and other kind of elective stuff not having that.
Yeah, it reminds me of a particular flu season where, you know, on the night shift, I did the QA of quality improvement of all the lab results. And it's like the initial, the immediate test is like flip a coin. So, and when you got the actual like lab results, like, nah, that's not working out. So yeah, it's yeah, the testing piece, huge challenges. So with that, we covered a lot today and a lot of, I mean, in my view, just like we're hitting on absolutely the critical issues for emergency departments. I'm extraordinarily grateful to our participants, Project ECHO, their team, NETAC, American College of Emergency Physicians, our panelists, and Nancy and Jolene, most grateful for your being here today. Thank you so much, all.
Thank you.
Take care of each other and be safe. Thanks. Bye.
Thank you, guys. Take care.